Well, good morning and welcome, and thank you for tuning in to Health Talk. I'm Dr. Victor Politi, the President and CEO of New Health, the Nassau University Medical Center, over on Hempstead Turnpike in East Meadow. So as healthcare in America is changing, New Health is part of that change. So this half-hour program will provide you with some essential information about our services and facilities that help provide top quality care that fits into your lifestyle. So New Health, we've been around for a while. We go deep into Long Island's history. What began in 1935 as a 200-bed general hospital has now become part of a unique health organization with multiple centers of care and a commitment to deliver excellent essential care to everyone at every stage of life. So you already know us as Nassau County's premier Level 1 Trauma Center. We have so much more to offer the community. Full-service, state-of-the-art healthcare centers, primary care centers. We have the A. Holly Patterson Extended Care Facility and New Health Family Health Centers. So our improvements are making us a leading provider of primary and tertiary care services that rival the best in the country. So today we are pleased and we have a great guest. We're going to talk about different endocrine problems with Dr. Rosenthal, who's basically our endocrinologist at Nassau University Medical Center. And he'll explain to us exactly what endocrinology is and what that involves and the different types of conditions that, you know, when you hear about them, you'll say, oh yeah, I know about those diseases, and what we could do for patients at Nassau University Medical Center for those patients. Again, we're not just the trauma center or the burn center or one of the best intensive care units in Long Island. We have full service hospitals for any medical problems that might ail you. So, Dr. Rosenthal, welcome. Thank you for being here.
Thank you, Dr.
I want you to start off by telling us a little bit about yourself.
Well, first I want to thank you for the introduction, but it's only fair to say that I'm not the entire division of endocrinology. Drs. Kumar and Lee and our fellows and our trainees, so it's a joint force working together. I graduated New York University School of Medicine many years ago, and following graduation went into the Air Force and did my internship and internal medicine training at Wilford Hall U.S. Air Force Medical Center in San Antonio, which is the Air Force's version of Walter Reed in Bethesda. And following which I served as a career medical officer both in the States and overseas. And when I left the Air Force, I did my endocrine fellowship training at Boston University. I then returned to the New York metropolitan area. I'm originally from the Bronx. And went into a referral academic level private practice in Bethpage. And at that time, I also actually joined the staff at NUMC. That was many years ago. I won't tell you how many, but many years ago. And about 10 years ago, I decided to leave private practice and devote my professional time entirely to academics, and in that capacity have been at NUMC since. Now, to answer your question, endocrinology is that branch of medicine which deals with hormones. Insulin, for example, in diabetes, thyroid hormone. It involves also pituitary gland, adrenal glands, testes and ovaries, the disorders associated with abnormalities in the hormones. Now, we do provide, as you said, a full level of, full spectrum of care for all these disorders. In the field of endocrinology, I think it is safe to say that the majority of patients that we see suffer either from diabetes or thyroid disease. We all know that there is an epidemic of diabetes. The World Health Organization estimated about 15 years ago that there were just over about 15 million diabetics in the United States, and project that in 2030, 15 years from now, there's likely to be 30 million, related to changes in lifestyle, length of life increasing, and an obesity problem. So we provide full level of care for these patients, both outpatient and inpatient, involving a full spectrum of therapy, both pills and insulin when needed, as well as counseling and instruction and lifestyle changes relative to exercise and weight control. And I think that patients do very well with all of that in mind.
What is diabetes? Can you explain for some of the listeners so they know what diabetes is?
Sure. In the simplest sense, it is an abnormality in the regulation of sugar, glucose, so that the blood sugar becomes elevated, and that has any number of metabolic issues that develop from that, and it is a major risk factor for heart disease, heart attacks, strokes, vascular disease. Patients can develop problems with their feet because of poor circulation, kidney disease, eye disease, nerve disease. In actuality, diabetes is much more than just an abnormality in blood sugar levels. It actually is a disorder of total body metabolism. In a real sense, we talk about in terms of sugar because that was the first thing many, many years ago, centuries ago, that was recognized with diabetes. So therapy is directed, as I say, at improving lifestyle because exercise helps lower blood sugar and weight gain helps raise blood sugar, so that's a problem. And as I often tell my patients, as we get older, we do not get better. And as the population ages, these changes become more pronounced. So we approach this with education and training about lifestyle issues, as well as a broad variety of oral medications, pills that are available today, and injectable medications. And that, of course, includes insulin, but there are other injectables that are not insulin that are very useful. So it's a very complex process and is one of the major health problems in the United States today.
So I hear a lot about following your blood sugar every morning. What do we recommend? Do we recommend people check their blood sugar when they wake up, after meals? And maybe explain to me a little bit what a hemoglobin A1C is, because that's what you hear a lot of people talking about, is a hemoglobin A1C is out of whack.
But the hemoglobin A1C is a very interesting test, and fundamentally what it is an index of the average blood sugar over the preceding 3 months. It may have been high at one point, may have been lower at one point, but in general, what range has the blood sugar been in? So that's very useful in evaluating the patient's general status. Now, that's an index, that's not the actual blood sugar. The point of checking the fingerstick blood sugars is to actually see what is the blood sugar now. If a patient says to me, how is my diabetes doing? My response is, what are your blood sugar levels? It's as simple as that. Now, different physicians will recommend a different testing schedule, and there's a lot of variation in that. Most people will be recommended that they check their fingerstick blood sugar before breakfast, perhaps before other meals in the day. There are times we check after meals as well when the blood sugar would be expected to be a bit higher, and that's especially true in pregnant diabetics, but other circumstances as well. So these are complementary kinds of tests. The hemoglobin A1C is a backward-looking, averaged-out value, if you will. The fingerstick blood sugars check what is actually happening at the moment. Those are obviously correlated, but may not be exactly the same.
So you mentioned pregnancy or gestational diabetes.
Yes.
So there's juvenile onset, there's adult onset, there's gestational. Why don't we talk a little bit about that?
Well, for the most part, the diabetes that we see is what is today called type 2 diabetes, used to be called adult onset diabetes or non-insulin dependent diabetes, even though sometimes insulin is used. And that really is the major healthcare problem in the U.S. and is related to the extending lifespan, reduced exercise levels, issues like that. In our experience, about 10% of our patients have type 1 diabetes, which used to be called juvenile diabetes. And that's something of a different story, because there's an explosive onset of diabetes with a loss of the ability to make insulin, total loss. And so those patients need to be on insulin, and medications by mouth simply don't work.
So type 1 or the old juvenile diabetes, these are people that have absolutely no insulin. Their pancreas is not making the insulin. And so you need the insulin for the sugar to work. You need the insulin for the sugar to go into the cells and to use as energy. And if you have no insulin, the sugar stays in the blood and it becomes very high. And from having high blood sugar, you lead to plaque and vascular problems and heart disease and strokes. So, I mean,
Exactly.
it's a simplistic way of putting it. But
That's pretty good.
yeah, but so a way that the readers, the listeners could sort of understand that.
Yes.
As opposed to the adult onset, which is a guy like myself, and you're in your 50s, and I'm gaining weight, and I'm not exercising, and I'm eating all sorts of wacky stuff, and I'm a setup for high blood sugar. And because my pancreas is getting old, my pancreas isn't secreting enough insulin, or whatever my metabolism is, I'm not able to compensate for that sugar, and then my sugars go up, which lead to vascular disease, heart disease, and strokes.
Absolutely. And that is one of the most important health issues facing the United States today. Whether you want to talk about this in terms of cost to the individual and lifespan and their health and well-being, or whether you want to talk about it in dollar terms of cost to the nation in caring for us. It's one of the very major problems.
I mean, it's almost ubiquitous. Everyone, either they know someone in their family or a friend that has diabetes or has high blood sugar, and they're being trained. They'll go to an endocrinologist at NUMC like yourself, and you will put them on some sort of monitoring scale, get an idea where their sugar is at, have them exercise, watch their diet. We'll have nutritionists at the hospital see them and talk about their diet, talk about exercise. If they're older and they're concerned about exercise, we can have them see a cardiologist. I guess they can do an EKG or a stress test to see if they can tolerate. People shouldn't just run out and join Extreme Gym or Gold's Gym. They should first check with their doctors to make sure they're healthy enough to it's like the Cialis commercial. Before you take it, check with your doctor to see if you're healthy enough to use this stuff. And I think that really goes for people in their in their 6th decade of life. They should check with their physician. Come to see you. You'll work them up for the diabetes, you'll work them up for the sugar, you'll have their heart and everything to check out, come up with a program for them, and then if they need it, after a couple of months of basically conservative treatment, you call it, maybe then you start them on some medication.
You're absolutely right. The foundation to the care of the adult type 2 diabetic is, the term that's used, of course, is lifestyle. It's exercise, diet, weight control. We go to great extremes to educate our patients about that. And we have a very intensive program, both for those patients who are hospitalized for one reason or another, and outside the hospital, diabetes clubs and educational lectures, so that the patients get an understanding of what they need to do and get the help and counseling to stay on track. So absolutely fundamental.
Do we try the oral medications, the oral anti-hyperglycemics first, and see if we put them under control?
Right.
And if they don't tolerate that or it's not working, then we start people on insulin? Is that usually the course?
Well, the most typical approach would be, as I've said, the lifestyle approach followed by oral medications. And for the most part, that's very satisfactory, works very well, but not always. And so the ultimate approach is with the use of insulin. And I would say that in my experience, perhaps 10% of the type 2 adult onset diabetics sooner or later wind up on insulin. But that means that 90% do not.
So insulin, that's the shot they take before meals or at bedtime. And they have some new long-lasting bedtime, like Lantus type of medication.
That's correct.
And they also have insulin pumps.
That is correct.
And you're available, the patients, if they come to see you, you have all of these treatment modalities and options open for them, correct?
Absolutely, absolutely. The entire spectrum is available and used as is appropriate. Absolutely.
So, for example, they'll start with the pills, then you'll move them over to insulin. The pumps, how does that, a lot of people talk about insulin pump. Are they any better than taking your blood sugar and correcting your insulin multiple times a day?
Most patients, the vast majority, do not need an insulin pump. The insulin pump is, if you will, a fallback approach for the patient who has not adequately achieved goal with all the other modalities, including injectable insulin. So the pump is a small device which is worn on a belt or something like that by the patient, with a very tiny tube and a very tiny needle inserted in the skin. And in that pump, there is a reservoir, excuse me, a reservoir of insulin, which is released partly on a computerized preset schedule, accounting for that patient's level of exercise, typical level of exercise, and meal intake. But the patient also checks their blood sugar frequently and can override that should the circumstances occur. So it is, in today's world, the ultimate fallback position for the control of diabetes. It does require a lot of work, and for the most part, patient work.
So from what I understand, if we're able to tolerate the medication, we're able to keep people's blood glucose level within normal ranges, that patients with diabetes will have no greater risk than a normal person without diabetes in developing some of these diseases. So why don't you explain a little bit? Here we have, I'm a diabetic, I need to come to see you, you put me on medication, my A1C is perfect, my fasting glucose is always good, I'm doing everything I'm supposed to do, I'm exercising. Can I prevent myself with diabetes from having a heart attack or from having a stroke, or at least increasing my risk from the disease of having those events?
Well, certainly, as I've said, patients who are not under control have vastly increased risks of heart disease and so on. If their control is good, there are any number of studies that have been done over the last 2 decades or more, showing that the better the control, the lower the risk of diabetic complications, including heart attacks. The risk can, if the patient is under really good control, the risk will be reduced to approximate that of someone who does not have diabetes. Of course, the risk is never zero, and we do not get better as we get older in all circumstances. But it's absolutely true that the patient whose diabetes is under good control can look forward to having little to no significant increased risk of diabetic complications.
And then you throw in a confounder like cigarette smoking, and you throw a cigarette into anybody's lifestyle, and it just throws the equation off, and the diabetes goes crazy, and every other disease, heart disease and stroke risk, all increases. So, I mean, I know that you really are an opponent to cigarette, and all of us physicians really try to stress to our patients not to smoke.
Absolutely. If you are a diabetic patient of mine, type 2 adult diabetic, and you say to me, what should I do to make my condition really bad? I would say, put on weight, sit in front of the TV and do no exercise, and while you're watching TV on your couch, light up a cigarette and smoke.
Now, these things you shouldn't do.
Should not do.
Half the people listening just saying,
no.
Now that's a good doctor, because I'm going to go sit on my couch and smoke and eat food. No, we don't want you to do that.
Taken out of context. This is what you should not do.
Well, they just sound bit that out, and they're going to tell their wife, "Let's see, honey, I can't sit here and smoke cigarettes." My doctor told me.
Please do not do that.
So, we have that going on for us, and we mentioned, patients needing to get evaluated by a cardiologist for exercise. But at NUMC, at National University Medical Center, diabetes affects your eyes. We have a full-service ophthalmology department with a whole bunch of ophthalmologists there all day long for our patients. We have a full-service podiatry department because, I think if you're a diabetic, the one organ or one of your feet are really important, because you get a sore on your foot or an ulcer, and people can lose their toes or their foot from a diabetic foot problem.
And frequently do. But you're absolutely right. At NUMC, we have available all the specialty backup that is needed. As you say, podiatry, ophthalmology, neurology, vascular surgeons, vascular specialists for peripheral vascular disease, cardiologists. Yes, you're absolutely right. We can provide all the specialty backup care that is required.
And I was amazed. I mean, I'm from Belmore. I'm Long Island, and I've been here about a year and a half now as the CEO. And I was amazed when I walked into this hospital, exactly the quality physicians that we have, like yourself, from NYU, Georgetown, Harvard, top board certified physicians, a $38 million ER, state-of-the-art board certified guys, 8 beautiful operating rooms, new intensive care units. I was like, wow, why doesn't anybody know that National University Medical Center has all this? And then I find out one of the top plastic surgical groups in Nassau County is based out of that hospital. The burn center is based out of that hospital. We have a full ophthalmology program with residencies from some of the top ophthalmologists in Nassau, from oculoplastics to retina specialists to corneal transplants to glaucoma specialists, are right there on the first floor. Podiatry, one of the best podiatry groups that really, these podiatrists are dedicated people. I've never seen so many doctors spend so much time with people's feet in my life. They just come down there and they just spend an hour with the guy's foot. They're just passionate about what they do. And I'm so proud to be part of that when I walk into that hospital. The place is immaculate, clean. Really, I'm so, I was amazed. Coming from Long Island, growing up, being out in Belmore, raising my kids in Belmore, to know that this service was available right there in Nassau. Yeah, you don't know that. You don't expect it.
I absolutely second what you're saying. It's been my great pleasure and honor to be associated working with the team at NUMC. I'm impressed in all directions, and I think our patients can be confident that they're going to be getting state-of-the-art care, which is second to none. And in my career, I've been around to any number of places, and second to none.
And I know we spent a lot of time on diabetes, and that's not even your super specialty, which is thyroids. And some of the work that you've done here has gained national prominence in the field of thyroid. So why don't we talk about some thyroid conditions? Sure. There are so many endocrine conditions. We're going to have you back. We're going to talk about testosterone. We talk about a lot of the hormonal issues with pregnancies. We didn't talk a lot of. There's so many hormones in the body that we didn't go into. So we just talk about what you love, thyroid.
Well, let me just say that thyroid disease. If you think that diabetes is common, let me tell you about thyroid disease. It's been estimated fairly recently that 10% of the U.S. population, so 30 million, maybe somewhat more than 30 million now, have a diagnosis of one sort of thyroid disease or another, and an equal number are walking around with thyroid disease and don't know it. So we're talking about maybe 60 million people, maybe more. The thyroid gland, let me just describe what we're talking about here. The thyroid gland is classically described as a sort of a butterfly-shaped organ that sits on the windpipe, the trachea, and the lower front part of the neck, and makes thyroid hormone. Now, thyroid hormone is the principal means that the body uses to control metabolism. And what you mean by metabolism is the sum total of all the chemical reactions going inside you at any given moment. So the thyroid really has its finger in every pot. And if the thyroid is not right, nothing is running right. Whether you want to talk about brain function or heart function or whatever it may be, nothing is running right. If the thyroid is overactive, everything is running about 1,000 miles an hour down the block, and you can sort of anticipate the kinds of symptoms that would occur. If it's slow, then everything slows down. So it's crucial to health, and we offer the full range of diagnostic and therapeutic measures that are out there today, from oral medication, thyroid hormone replacement, to radioiodine therapy for overactive thyroid. So we offer the full range of diagnostic and therapeutic approaches. Thyroid cancer is the most rapidly increasing cancer in the United States. A lot of reasons for that, including better diagnostic techniques, but we see that more and more often. And diagnosis can be a problem because thyroid cancer typically presents as a nodule or a lump in the thyroid, and in women in particular, this is very common. The vast majority are benign. So we are faced often with the question of diagnosing the people who are most at risk for thyroid cancer, because they will be sent to the surgeon rather than just operating on everybody, because most people do not need that surgery. So the cutting edge of medical science today in terms of cancer is the use of genetics to diagnose who is most suspicious for having cancer. And in thyroid disease, we do that by doing a needle stick, a needle biopsy in the nodule, and when necessary, subjecting that to state-of-the-art genetic analysis. And we do that, we have that available for our patients at NUMC. And even the therapy of thyroid cancer, which obviously the foundation is surgery, but there are some patients who need medication, and the cutting edge there today is the use of medications which are targeted to the genetic mutation causing the cancer. And we have that available, and we do use that in the appropriate patients. So this is on the cutting edge of medical science, and NUMC is involved in that. We've been involved in establishing guidelines for the radioiodine therapy for patients being treated with radioiodine. Those standards that we participated in developing are now the worldwide standard of care, we have published in the field of the genetic diagnosis of thyroid cancer, and are shortly going to be publishing a review of the targeted, it's called genetic therapy for thyroid cancer. So our patients they're in good hands, and they have the very best that modern medical science has to offer. They have that available to them.
And we talk about thyroid disease, and certainly not giving you enough time to get into it, but it's that organ in the front of your neck that controls a lot of your hormones in your body, and it develops abnormalities, and you guys have the equipment and the knowledge to diagnose it and treat that. And when it comes to cancer, we've done some of the pioneering work and are on the cutting edge. Other hospitals that have a big budget and they can be on TV every 20 minutes talking about how great they did and how fantastic this is or that is. We are right there with them. It's just we aren't advertised. I mean, we don't get out there. I don't have the money in a budget to spend $100,000 for a 15-second spot at 3 in the morning to talk about what you're doing in my hospital, in our hospital, for our patients. But you're doing it, and people need to realize that there's that NUMC has this capabilities. And I'm certainly not doing you justice in a half hour, because you're just such a wealth of information and knowledge, and you're just so happy. The patients love you. And you're just able to just connect with them to treat their diseases. And so, Dr. Rosenthal, you're at Nassau University Medical Center. If the people listening needed or had some endocrine problem, diabetes, or anything, thyroid disease, how do they reach you?
They can call our appointment desk, which is 516-572-4848. 572-4848. And arrange an appointment. If for some reason there's some urgency, or their referring physician feels that there is an urgency, they can leave the message there. I will personally get the message. We'll take care of it. They can also, in an emergency situation, call our Department of Medicine, which is 572-6501, 6501. And they will be sure I get the message also. And we will do what needs to be done.
I mean, and that's so important because you know, the patients out there, they don't realize they have this type of service right in their backyard, and such great physicians. So I want to thank everyone for listening today, and I hope you learned a little bit about endocrine and diabetes and thyroid and all sorts of stuff, and got to sort of get an idea what kind of physicians we have at National University Medical Center and the services that we provide. So again, I'm Vic Pleedy. I'm the president and CEO. I want to wish you guys and ladies a great day today, and you know, stay healthy.
Indeed.
Okay.
Thank you. It's been my pleasure.
Thank you, Dr. Rosenthal.
Thank you.
Bye.
Bye-bye.